a teacher with it. But
Oh, I just got a text from Miss Weatherhead.
okay.
Can someone please send me the Zoom link? I'll send her the Zoom
I
link.
emailed it to her at 6, but you can send it to her.
I'm gonna send it to her right quick. Um, Let me find this one.
So it's the dash and the NPDI, and what's the other one?
The UEFI, Upper Extremity Functional Index.
Okay, thank you.
That was the one, if y'all remember in class, we had like our lab partners, and we had to ask each other, we had to get each other to fill it out, and then you added up the scores.
Yes.
Mm-hmm.
I remember that.
Me and Mary Claire did that, and I think like it goes up to 80 on the upper extremity. Hi, Miss Weatherhead.
Hi there.
That was quick.
Hi.
Sorry for the
My email takes a while to get caught up when I come home and hook my computer up.
Yeah.
So I'm looking, I can't find the link. So I sent Jesse a message and my emails popped up. So
Perfect.
You paint your room, or has it always been that color?
no, painted it. In fact, part of it is painted. The part behind me is painted.
It's a pretty color. I like it.
Thank you. We have a new desk so that I have a little more space to sprawl, since it looks like I'll be doing some of this stuff from home for a while. So
New chair. Is that a new
same
chair?
chair.
Oh.
It just stands out against the blue
Yeah.
as opposed to the pale yellow that completely washed me out.
Well,
All right, so I interrupted. What questions do you have?
We were kind of just breezing through to start with the review that we had. I think it was like the 9-page or whatever it was for the upper extremity, cervical, TOS, TMJ conditions going to MMT. And I don't know. I know which Diana keeps dropping off. I noticed she's not on again. She had questioned a little bit about the arthrokinematics, and we were going to start talking about it, and she dropped off, and she came back on, and we were on something else. We were talking about the functional outcome measures a little bit with that too. So I don't know. I guess we will be at your mercy and what you feel like we need to concentrate on. Maybe give us some direction. I'm going to see in a little bit.
Okay, well, some of the exam is the principles of the manual muscle testing and goniometry, and it is more related to specific tests. So there will be questions that might list in sitting, or which of the following would not be tested in sitting. And it'll have different grades. So, it'll say, like, just off the top of my head. So is the middle deltoid grades 3 to 5 tested in sitting?
Yes.
Okay. Is the middle deltoid grades 0 to 2 tested in sitting?
No.
So it'll be different muscles. It won't be the same one multiple times, but it will be different muscles. So it's really just remembering what the test is for that muscle, which can also be very simply remembering what the muscle does. And how do you do that against gravity?
Right.
And how do you do that? How do you do that motion gravity minimized? So it is based on some of the information from that lab guide that I keep reminding people to be looking at. There is a little bit of nerve questions. There is some, if you're testing, like, for example, if you're testing shoulder internal rotation, which of the following muscles are you testing? Or which of the following group of muscles is not being tested? So you have to know, what are the internal rotators? What are the external rotators? Again, you learned that in 120, and your lab guide lists it. So that's a valuable tool. And there is a decent portion of the exam is that, but then it will go on into the conditions. And it may be special tests. It'll have some questions, kind of like the quiz was, about a condition, and what special tests might be positive for that condition. It's more big picture in terms of symptoms. It's not going to be minutia. You're not going to have to be able to identify whether something is a tendonitis or a rotator cuff tear, because we PTs can't do that very well. We can know that the tendon is involved, and we can suspect that there's a partial tear or a complete tear, but you're not going to be doing that. That's not the discrimination that you have to be able to do, but you have to be able to recognize if a patient has, for example, a reverse total shoulder. What's the difference between the patient who has a reverse total shoulder and a patient who has a total shoulder?
If it's complete or incomplete.
If what's complete?
The rotator. Oh no. I'm sorry, I'm having a headache.
So what's the difference between a patient is going to have a shoulder replacement? What's the difference in the patient who has the reverse total shoulder or the standard total shoulder?
That's the tissue, right?
Yeah, the muscles. So if you have like your rotator cuff muscles completely torn out, and they're not, like you were saying, with like the noodles, if they're like angel pasta hair kind of like, so there won't be way of fixing them. So they will do the reverse. But then if their muscles are still, or the tendons are still kind of like, they still,
there's some integrity to them.
Yeah.
Right. If they have if the tissue still has good integrity, if the muscles are intact of the rotator cuff, very good.
And is this also, they attach it to the scapula, right? Is it like anchored at the scapula? Because why do I remember something about how when they put it in, they use the scapula as a stabilizer for it?
Okay, so with either shoulder procedure, when we do total shoulder, when we do joint replacement, we replace both sides of the joint. Okay, a partial would be they replace one side. So like if the glenoid fossa is still in good shape, but the head of the humerus was injured in a trauma, then they could replace just the head of the humerus. But in a total joint, they replace both sides, the whole joint or the total joint. So when they do a total shoulder, they put a new piece in that glenoid, and so that they've got a new surface there, and they put a new piece, they replace the humeral head with a new piece. But it's still the same normal alignment. Excuse me. When they do the reverse total shoulder, they do, if this would be where the glenoid is, excuse me, so this is this shoulder. So normally this would be the glenoid, this would be the head of the humerus. But I have to have a good rotator cuff that can control the head of the humerus. So when I don't have a good rotator cuff, they take, some crazy fool came up with the idea that instead of a glenoid on this side, let's put the head sticking out here, the ball, and put it out that way, and let's put the socket out here. And then the deltoid can create this motion, and we don't have to have a functional rotator cuff.
It's kind of cool.
So the biggest determinant of anyone having a shoulder replacement is pain. That's the reason they have them.
Mm-hmm.
So if they don't have pain, there's no reason for them to have a surgery. We can still work on stabilizing and strengthening the muscles, right?
We can try, yes. If their rotator cuff is shot,
Yeah.
I mean, there's only so much we can do with a rotator cuff that is in really bad shape. They've just worn through too much of the tissue. And if you recall, even when they do a repair, it doesn't guarantee that they get full function back.
Right. But the pain is gone, and that's what the goal was.
Mm-hmm.
Yes. Yes. And I've seen an article that I was reading the other day said that they're finding in the rotator cuff, actually, no, it was a course that I'm doing online, a short shoulder course online. I just haven't had time to go back and finish it. But they said that they're seeing, the evidence is showing that with a rotator cuff repair, we used to say that after a year, that was pretty much what you were going to get. But the evidence is showing that patients can continue to make progress even 4 years later. The healing from that can continue to make progress even 4 years later. We're not treating them in that time frame. But they don't have to think, 6 months out, that's all I'm ever going to get, that the tissue will heal more and will grow into the bone, because they screw it back into the bone or staple it back into the bone or suture it back into the bone. They use different types of anchors to put the tendons reattached to the bone from a rotator cuff tear. So they can heal more. That doesn't mean they get back to normal or get back to a healthy tissue, because like Diana remembered, that's the best way I can say it, Diana, for patients, if they, because you don't want to say, if they sew together crap, you're going to still have crap. So you say, if they sew together angel hair pasta, they don't have a whole lot, it's not good tissue quality. But if it's thicker, denser tissue, more like a lasagna noodle, if they're reattaching that, then you've got more integrity of that band of tissue. But if it's just kind of fragments, if it's frayed, that's not going to grow back well. That's not going to scar together well enough to be functional tissue.
Is that throughout all joint replacements?
So the rotator cuff is a special thing. I mean, the shoulder is special. The knee, once they find their quad, they do much better. A hip replacement, they can rock on those things and do really well. And most knees can function because the way we use the range is different in a knee, and the way we use the range is different in a hip than in a shoulder.
Yeah.
Remember, because the shoulder is the joint that we give up stability so that we can have more mobility. And so when they replace the shoulder, they have to give up some of that mobility to create the new stability. So you lose some range. You're not going to get full range with a shoulder replacement, but you didn't have it before you had the replacement. And you had a heck of a lot of pain. And the patients, even early on, often say, the pain's better. I'll get this moving some better, but I couldn't use it before and it hurt. So even if I can't use it well now, it's better.
Mhm.
They still can have an expectation a little more like the total knee patient or the total hip patient, thinking, oh, I'm going to be, you know, pitching baseball, I'm going to do whatever. And that's not necessarily the case with the shoulder. Again, it doesn't have as much stability, so it has to be protected a little more.
Mhm.
Did that help?
Yep.
Yes.
Can I ask a kind of backtrack question? Because I've just had an epiphany, even though you've been repeating to look at your lab guide for the past few weeks. So I've been focused on like the conditions. And I did the lab guide like at the beginning of the semester, like the ones that you gave us. And I haven't really thought that much of it, but it's important to focus on the lab guides, isn't it?
Yeah.
As much as the other, I mean, you do need the conditions. It's going to have some of each.
Right, right. But I've been just kind
but-
of like focused on those like main PowerPoints, and I should make
The
sure.
lab guide prepares you for the practical too.
Right, right. Okay.
And the lab guide is how you should be checking each other off.
Mhm.
And the reason I've been stressing it more is that I was finding when I was going through, people had gotten checked off on their peers doing a triceps manual muscle test sitting like this. And I said, that's not the test position. Oh, that's what I've been doing.
Yeah.
Well,
Well,
that's
a
not
lot of
what-
that too was on Physio U. Like I had watched the Physio U videos are a little different too. And then I've just been watching all kinds of stuff. But okay. So focus more
and
on
I've
the
tried to
lab guide.
I tried to put on the lab guide too, where when I differed from Physio U,
Yeah.
I'd put under, below it, it says, Mrs. Weatherhead prefers this position. Because in
the
a
same with, like-
screening, when as a PT, when I do a gross muscle test, I'm not doing the specific manual muscle testing. I'm doing that screening where I say, hold your arms out here. Don't let me push them down. Hold them out here. Don't let me push them down. Don't let me push in, like Paul Markey has been doing on some of those videos, and just, not putting them in prone for external and internal rotation. He's just checking it. He's just gathering information. We have to teach you the true manual muscle test because that's the standard.
Okay.
But the screening tests can be done in other positions. That tells me, oh, there's some weakness there. Now I want to be more specific. And now I want to go make sure that I give it an appropriate grade. Or I'm just going to say moderate weakness, resisted external rotation in neutral, sitting in neutral, moderate weakness. That's a description. You can't necessarily reproduce my moderate weakness, my grade of moderate weakness. That's where the manual muscle testing following standard procedures is a better test. But as a PT, I don't necessarily go through and do manual muscle test on everything. If I clear an area, it's strong, I don't need to go back and look for details when there's so much else I have to check.
Well, do you think that, like, how often do you think that we will manual muscle test? Like, is it going to be something that we do pretty often?
A lot. It really depends on the environment you're in. Kelsey said she's not doing much manual muscle testing, but other students are.
Okay.
And it does depend on the environment. Now, some of the acute inpatient, they may not be doing a full on manual muscle test, but like when we do the lower extremity, if the patient is sitting and you have them flex their hip as high as they can, if they can go full range of motion, as their passive range, we may not apply resistance. They may be weak, but we know that it's at least a 3 that
So
you can.
It's kind of like a base of the
Mhm.
foundation. I get it. Okay, it's coming together. I'm slow, but I'm getting
No,
there.
that's good. Yes.
Okay.
I'd rather you get there.
I get the
Um,
point of it, but I'm just kind of like, and now I'm like, oh, well, we were building cases off of manual muscle testing. And I just realized that I've been completely studying wrong for this class. So I have a lot of work to do.
Well,
Now
where
I
you're going to
know.
be doing, there's going to be there's going to be questions about the conditions too.
Right. Oh, I feel like
But
I'm getting there on the conditions. It's just like I keep drawing blanks and then the tests are starting to come together for me. Like, you know, I'm getting there. I've just been having a time with it. But I think I've just been having the wrong approach on the entire everything. But okay.
Miss Weatherhead, I think Annette had a question earlier that she didn't get to ask. I don't know if she still has that. Annette, do you still have a question?
I don't remember what question.
I was afraid that might happen. I remembered you said, could I ask a question? And we didn't.
I don't think it was me.
Okay.
I was
I have,
I was listening a lot. I think Diana had a question that she was asking and then she froze.
Oh, yeah.
yeah, I forgot what was the question, but I have another question about something else.
Can you
Okay.
ask about the labrum?
Yeah.
Yeah, but I forgot about it. I have another question about the cervical. So
Okay.
do you remember? Well, of course you do remember. In your quiz, you you wrote about the wait a minute, the oh my gosh. Hold on, I just had it
Annette,
right
cover your ears.
here. Okay, the classification, the treatment-based classification on the cervical. So I know that we said we're gonna be going based on whatever the patient is, right? But my question is, okay, so what about if I have a patient that comes with pain, but he also has headache? Like,
So which is the biggest problem at the time? And that's why the question didn't put you in that situation. The question on the quiz was about a patient with radiculopathy. And what is radiculopathy?
pain. Well,
Moving.
well,
thing.
it's
Pain that radiates.
pain that goes into other, you know, in your upper
Pain-
arms, not just
Pain that
centralized.
radiates into the upper
Yes,
arm. So
moves.
what do you know about how do we treat radiating symptoms? What's
We
our
try to
principle?
centralize it.
Right,
Centralize the pain.
right. That goes back to first semester.
Traction.
Yeah.
Traction, and then we talked about it some in Therex, about direction of movement that we do, and you'll get more of that in late when we do the lumbar spine. But so centralization. So with a patient who has radiating symptoms, the first thing we want to do is centralize those symptoms, right? So they would automatically go into that category,
Okay.
the centralization category, right? If
Yeah.
they've got radiculopathy, they may have a headache, but it didn't give you, I won't throw all of those things at you and make you prioritize, because when you have a real patient in front of you and they're saying my head is killing me, then where do you focus? The headache. Where do you, is it a cervicogenic headache, or, would some suboccipital release help? Would some manual traction maybe help just stretch those tissues and give them some relief? But we wouldn't jump right into stabilization exercises if they've got a killer headache.
Yeah. Okay.
Does that make sense?
Yes. I just thought that, if we would choose between one or the other.
If you are asked to choose between one or the other, it will be something that
What's
you
the
can identify.
Okay.
What what it would be. If they needed to be headache, if it's a patient who is improving, and who has full range of motion, no longer has radiating symptoms, and is progressing towards function, where should we focus? For that patient, that category might be that, like the aerobic exercise or the general conditioning exercise, because they need that overall. So there aren't going to be questions that trick you. If you think about what's wrong with this patient, I'm not going to have it be, oh gosh, I've got to figure out what's going on with the patient that you can't see. What you need to see would be there in the information.
Okay. Thank you.
You're welcome.
I have another question. So on the radiculopathy, one of the symptoms is rotation of like cervical rotation less than 60 degrees. Is that with other stuff? Because I feel like in our class there was quite a few people that had cervical rotation. Is that just one of the many, like they go together?
Yes. So if you look at the slide that was the picture of kind of the chart that had the different sections, not the one that's got the C5, C6, C7, but the one that was the kind of the big picture of radiculopathy that was somebody else's slide. Yes, Diana, thank you. That one. There's a cluster on there where it lists the special test. It lists Sperling's, cervical distraction, rotation less than 60 degrees, and upper limb tension.
Right.
Right? Is that right,
I mean, I
Diana?
had that. I just didn't know that it was like all of them involved, or they all separately.
So that on that section, and I mentioned, but we didn't go into detail on that section. So each of those tests is something that could be positive in someone with cervical radiculopathy. The more of those tests that are positive, the more likely it is that it's cervical radiculopathy. If the patient only has 2 of those things positive, it may or may not be. They could just have some other restricted mobility and let's see, Sperling's, and some upper limb tension that's maybe not related, that affects their causes carpal tunnel symptoms. But the more of those tests that they have that are positive, the cervical distraction, the more of those things that test positive, the more likely it is that it is that the patient truly has cervical radiculopathy.
Okay. I was just unsure if that was like in itself like means you have cervical radiculopathy, or if it was just okay. Thank you.
No, by itself, no, but it's a component that could be, but then you put it together with the other tests, and that tells you a better likelihood or not.
I got you. Thank you.
You're welcome.
I have a question off the shoulder lab guide.
Okay.
It was talking about the scapular adduction with middle traps, but then it has a question at the end of that section that says, does the middle trap create upward or downward rotation? I was confused because it's in the, I don't know. I was just trying to think what I put downward rotation, and then it said, so if you're testing it and see rotation of the scapula, what does that mean? And I was kind of confused on that part.
Okay, so it really, the mid trap, the upper and the lower trap both create upward rotation. The mid trap muscle fibers run this direction. They contract this way. They really don't do rotation. So if you are testing a patient, trying to do a mid-trap test, you've got them in prone with the shoulder abducted 90 degrees. And so this is me in prone. And the scapula downwardly rotates. That's not the middle trap. That tells you that something else is kicking in, because the middle trap can't downwardly rotate. The upper trap doesn't downwardly rotate. So what muscle downwardly rotates and retracts the scapula?
The rhomboids.
Yes. Yes. Does that make sense?
Yes, that does make sense. So when it does downwardly rotate, it's substituting the or it's the rhomboid substituting for the middle traps.
Right, right. And so you can have muscles that dominate for other muscles because all of, those work together to retract the scapula. But if it goes one direction and you kind of cue them, oh, try and keep it straight here, and they can't, then it'll tell you what muscle is dominating. So for example, a patient doing shoulder flexion, if you're having them do shoulder flexion and the arm keeps deviating across this way, keeps coming across here. So we've got our, what are some of our shoulder flexors?
Your deltoid.
Anterior deltoid.
Bicep.
Bicep does a little bit. Our pec helps start that motion. So if the patient goes like this and you try and get them to stay in neutral and they keep going like this and they're horizontal adducting, what big muscle is more likely to be doing that?
Pec major.
Pec major is dominating. So you can tease out the muscles by looking at, is there something that's not quite, that they're not quite doing smoothly? Now you just have them repeat it. So, okay, oh, can you do it right here? And if they do fine, then okay, cool. If it goes up the way it's supposed to. But if they consistently do it this way, then you start looking and you start palpating and maybe you test the pec major and say, oh, wow, that's really strong. And then you try and isolate a little bit more, but man, they just can't, I can't palpate much contraction of the deltoid. So we just kind of look at what's going on, and you have to understand the muscle principles. What does the muscle do? What other muscles help with this motion? Again, that's why they're all listed on that guide. Okay.
The
Next
guide,
question.
the magical guide.
You better believe there are going to be a few questions from that because that takes a long time to put together. But it replaces, it's to be an easier thing to use than the textbook. But it also is, you can look at the textbook and it's got pictures, which is great. So you can use that as a supplement, but the guide, again, makes you do origin, insertion, and nerve supply. So it's just a forced opportunity to review. That's the part of the purpose of that.
I'm actually really excited because I've been struggling to figure out how to attack all this information, and that I haven't already talked about that, but yay, thank you.
You're welcome.
Do you think do you have a key to the exam review that you gave us a few days ago? So, because I've been working on it, but there was some stuff that I missed and I was curious. I want to make sure I'm saying the right thing.
No, I don't have a key for that. I just pulled it off the slides. But if you ask me questions on the parts you're not sure of, I will gladly answer them.
Let me take a look. 1 second.
Can you, what was the Hoffman's sign for?
Hoffman's sign is part of the myelopathy.
Okay.
group, and it's just an indication that there's an upper motor neuron lesion. That's where he flicked the patient's finger. And when it caused the thumb and index finger to come together like this. It was hard to see on one of the videos, but I think it was more obvious on the other one, on those two that were on the myelopathy, on the slide that had myelopathy. There were the two short videos where he tested the patients, and that's where I told you one of those patients had, I think, was tested and found to have MS, and the other one, or did they rule out MS? One of them had a thyroid problem, I think, which was kind of surprising, that it was causing the symptoms that they were having. But
So the stenosis, like myelopathy, is it like what follows after having stenosis?
it can. It's not absolute, but it
Because it can
can.
be due to trauma too, right?
Right,
Or-
right. And if you can have stenosis that's not compressing the cord. So stenosis that is central canal, that's where the spinal cord goes through. You have
Mhm.
central canal stenosis, or you have foraminal stenosis. Foraminal stenosis, what kind of symptoms would we see?
On the nerve root end.
Yes, good, very good. So we would see nerve roots impacted. So we would see radicular symptoms, remember, because radiculopathy can be caused by a lot of different things. Anything that puts pressure on the nerve root or irritates the nerve root, like a herniated disc with the biochemical changes. So radiculopathy is a big part of all of these conditions. Anything that sends symptoms into the upper extremity is a radiculopathy. So there are lots of causes. That's kind of why we started with that one. Stenosis is when there is narrowing of the canal. Again, central canal is what can lead to myelopathy when it puts pressure on the cord.
Okay.
And myelopathy, what's the difference between myelopathy and radiculopathy is myelopathy is going to can affect a lot more pathways and a lot more extremities, where radiculopathy is going to affect that nerve root or those nerve roots that are affected. If it's multiple levels, it's going to affect those. When you affect the cord, you affect upper extremity, lower extremity, depends on where the damage is, but you got a whole different complex going on when you're affecting the cord as opposed to the C5 nerve root.
And the Bakodi signs, is that just specific for C6 impingement? Generally
it's considered more C6. Could be a little bit C5, but it's just one of those, it's something that you just happen to see. You don't necessarily do a test and say, put your hand here, does that feel better? I mean, typically what we'll see is the patient has figured out that, and they'll rest like that, that's where they're most comfortable. I was in church once when we were living in Florida, and happened to be sitting next to a physician who was an osteopath, a really good doctor. But we just happened to be sitting next to each other. I knew her. And we were sitting on, if we were facing the front, we were off to the left side. So we had to kind of turn our head to the right, our heads to the right to watch. And I looked over, and she's sitting there, and she just keeps going with one arm, and she's doing this with her hand, and she's miserable. And I think it must have been the side next to me, because I picked up a couple hymnals and put her, I think she had a jacket next to me or a sweater or something. I put her sweater on it, and I whispered, try resting your arm on this. And she still wiggled a little bit. So I grabbed her purse and set it on the other side so that she was sitting with her arms supported instead of the weight of them hanging down, so that she had her arms rested so that her shoulders could relax. And then I whispered, "Don't look at him, look straight ahead." And so she sat, everybody else is looking this way, and she sat there facing like this with her arms relaxed. And when the service was over, she said, "Oh my gosh, that was so much better. I didn't think I was going to be able to stay sitting in here. It was killing me." It's just applying the principles. So we were causing some compression on a nerve root, or that was already irritated, by sitting in right rotation. And so taking her out of rotation and then unloading the weight of the upper extremities allowed her to relax the neck muscles and minimize compression, and she felt much better. And this was a physician who was a really good osteopath, but didn't have a frame of reference, didn't have a understanding that she could positionally fix it, or maybe she never thought to use hymnals in her purse. I don't know. That's a home health PT too. So all I did was apply the principles. How can we take the load off the tissue that's being a problem? Go ahead, Diana.
And so with the cervical flexion and rotation test, are we just looking, we're not us, but you, looking for like reduction of symptoms? Because I think in the PowerPoint it says when you flex, you get more opening of the foramen instead of like when you rotate or you extend, then those ones close. So are we just, that's what it's testing, just for like relief?
So the flexion rotation test is actually used for cervicogenic headaches. It's almost exclusively for that. And what we do when we flex the neck all the way up, we take out the motion. We kind of lock the facets below. There's no room for them to rotate when we take them into end range flexion. You can't get that glide any further from end range flexion. So we put the person in end range flexion. And if all those other facets are kind of locked out, remember that C1-2 is more on this plane than that 45 degree. So it's not going to lock out with that flexion. So when we take them into end range flexion and then we keep them tight there and we rotate, passively rotate, we're looking for the amount of rotation that they have. And it shows us that there is tightness and restricted mobility if one side, in areas in the C1-2 area that can cause a headache, if one side is has significantly less range of motion than the other. So remember, C1-2, we should have about 45 degrees of rotation to each direction. With this test, what you might see is they have 15 degrees to one side and 30 or 35 or 40 degrees to the other side. That's a positive test when it either reproduces their symptoms or they're really limited in motion. And the limitation in motion is kind of the primary thing that says this is an upper cervical problem. They are limited in motion in the upper cervical spine in one direction, and that limitation in motion is contributing to the headache. So if we can restore that motion, it can be chronic. It can be something that maybe gets calmed down enough that they don't have the symptoms, but they still have restricted mobility, so they may still need treated for that. But it can recur with stress, with abnormal posture. If they find themselves sitting on a low chair, or even like going to the beach and sitting on a lounge chair where you've got more forward head posture as you're sitting there reading or talking to your friends.
So does this mean it's the neck flexors that are weak?
Nope, because it's passively done. So I would take your head and flex it all the way, flex your neck all the way. So you're laying on the table. I take your head and I take you into end range flexion, and I get a feel for what that feels like there. And then I keep you flexed, keep your chin tucked, and I turn your head to one side and back, and then I turn it to the other. Ugh, it doesn't want to go that way. It goes this way. It doesn't want to go that way. If it doesn't go to the right, I'm going to treat that right suboccipital area. I may need to do some joint mobilization, but I definitely am going to want to do some suboccipital release. And remember the little, how I told you, you can really get a lot of good by actively moving the opposite direction, because you're getting those joints moving, because we've got, when a vertebrae moves, both facets, the on top and the bottom move. So if I move one vertebrae, it has two joints on the bottom, two joints on the top. If I'm only moving a little bit of motion at one, I'm affecting at least four joints. But we also can't isolate it well, so I'm affecting more joints. So if that hurts going to the right. Does it hurt if you go a little bit to the left? Okay, good. Just go to the left. Small range, just left and back, left and back. Does that feel okay? Yeah, that's okay. I'm moving fluid in the joint. I'm contracting muscles that have been guarding, but I'm putting them in a pain-free spot so they're not afraid of that pain. And so I can kind of create, okay, now let's see. Okay, it starts to hurt there. Well, you were here before, and now you can get to there. Okay, good. Well, don't push it that way. Let's go back over here and let's try a little bit more motion. And maybe I have them go up a little bit. Maybe I have them go down a little bit, but I have them go in the direction that doesn't hurt. And I usually will have my fingers on, trying to feel if we're getting motion in that area. Good. Okay, now try again. Maybe they look up this way. Okay, don't do that. But just have them move in the opposite direction, and you're getting the benefits of joint movement. And often that can significantly help settle that down. They still could possibly need the PT to come in and do a mobilization, grade 5, but they may not. You can often work around that. And sometimes you have them do this and they turn their head to the right and they get a pop, because they just took the pressure off enough. And now they can go that direction and the joint will pop, which is that gas release. And they'll say, oh, that feels better. And all you did was have them actively move.
Does this happen more with rotation? Does it happen with flexion and extension also?
So flexion and extension motions are going to be part of that. And again, it depends on what direction they have pain. But rotation is often a direction that people are very limited. And often because the facets are going to be doing this, the one on the left, I am turning left. I don't know if that's reversed at all for you, but I'm turning left. And so my left facet is going to move down and back a little bit. And my right facet of the same vertebrae at its joint is going to move forward and up. And so flexion is both of them gliding forward. Extension is both of them gliding backward. Rotation and side bending have them going kind of opposite to create that motion. So I can get a little bit of flexion on this side with my rotation, or I can even have them do some flexion. I can have them do some chin tucks gently. So yeah, we can play around with it and figure out what makes it settle down.
Mm-hmm.
Okay, good. What other questions?
One thing I was looking at on the exam review was the first section that was talking, sorry, hey.
That's a happy sound. That's okay.
Sorry. About the exercises, with the increasing range of motion exercises, was that just be like isometrics, or I was just couldn't find that in the PowerPoints.
No, because that's a review from Therex.
That's what I was thinking, but I was like
Oh,
trying to
shoot.
find.
Oh, shoot. And that's why we need to, that's why we postponed the practical, because you all need to be putting the exercises into play. You all need to be looking at a patient scenario and having them exercise. So what exercises are useful to increase range of motion?
Does that question mean like the hold release, like the PNF and
Yeah, I was thinking contract relax.
So contract, relax, so stretching, right? Because that's part of our stretching that you're looking at. So stretching can increase range of motion. What are some range of motion exercises?
The active, is that what you're asking for? Active, passive, active assisted?
Yes. Those are,
What-
how do we increase range of motion? How do we increase shoulder range of motion?
do like
What
the
are some
By moving it.
wall walks where you move your hands up the wall and back down?
Yep,
With the-
Codman's pendulum,
Mhm.
just to kind of get it loosened up. How about the wand exercises or the cane exercises? Where you're using
the
that.
pole.
So that's more a stabilization. That's not going to increase range of
Yeah,
motion.
okay.
When we're talking range of motion, the overhead pulleys, where you use the pulley, where you pull down on one side and bring the other arm up. The like I said, the cane or the PVC pipe, where you take it overhead and you use that to help create motion, where you push it out to the side, create abduction with it.
Would we
It's
do
kind of like, ooh, sorry.
no, well, I was just going to ask, so we would think more of passive range of motion and active assisted range of motion as opposed to active?
That was the same thing I was gonna ask.
So what does the question say, Mary Claire, that you were looking at?
It just says what exercises increase range of motion. And then at the top it says versus neuromuscular control versus stretching versus strengthening versus dynamic functional activities.
So yeah, just thinking about what does this patient need, which exercises are most appropriate. So how do you know if they need range of motion or stretching? How do you know what kinds of things they need? Range of motion, if they're not allowed to stretch, they're a post-op patient, they're not allowed to be stretching, we're going to take them just to the range that's allowed, or just to a barrier, and we're just going to gently work there, and we're not going to do heavy stretching on them to get motion that could cause damage. So early on with our shoulder patients, rotator cuff patients, we're often having them do passive range and active assisted range. And so that can be using the cane, putting their hand on a table and leaning back in a chair where they roll back. So they're doing kind of a passive range. They're not actively lifting their arm, but as I scoot my body back on the chair, as I scoot back, my shoulder goes into flexion. I can take that shoulder into flexion, and then I can scoot back, and I can scoot away and scoot forward, and I'm doing passive range of motion at that shoulder.
Could you do like if someone like has been in a cast or something, and then you take them into like the picture, I always think of the picture with the guy who's holding the band that's attached to something on the ground. I can't remember what the name of it is, but is that considered an exercise? So that's a stretch.
That was a sustained stretch, and it's a low level stretch, a low intensity stretch. Remember we said that we only hold most stretches we do 30 to 60 seconds,
Right.
but that one we can do 3 to 5 minutes, or some protocols will even say longer than that, because it's a very light load.
Okay.
But it's a sustained load. It's the band is on there just to create a continuous low level tension. And over time we get that creep back from Therax,
Yeah.
where the tissue, the viscosity, viscoelastic properties, where the fluid moves, and we get that creep, and then the change creates more of a permanent change in that tissue. So after if you've got that patient lying there getting stretched into external rotation for 5 minutes, when you release that stretch, then one of the first things you would want to do is either isometrics at that new position into external rotation isometric. So if you've just stretched me back this way, I really have not functioned in this area. If I started here and with this slow sustained stretch, now I've got this motion, my external rotators didn't take me back there. The stretch did. So now you want me to actively use those external rotators in this range because I haven't used them before. Now you want me to do that. And so you can have me do some isometric exercises in external rotation or very light resistance, but you don't want to put a heavy load because we've just created this tissue that's elongated and hasn't been there in a while. So we have to protect it a little bit, but man, we want to use it. We want to use the muscles that won't let it tighten back up. Does that make sense?
Yes.
So things, let's see. I'm looking at.
Can you quickly refresh my mind on the scapulohumeral rhythm?
Okay, so scapulohumeral rhythm, remember the first 30 to 60 degrees of raising our arm is really just the humerus moving. So if this is the glenoid off here on the side, and this is the scapula. So first 30 to 60 degrees is really just the humerus moving. Then to allow for more mobility, now as the humerus continues to do its superior roll and inferior glide in that glenoid, the scapula is also upwardly rotating. Okay, and it's going to protract a little bit to allow us to get that motion. And so we've got motion happening here and motion happening at the scapulothoracic juncture, okay, that false joint. So we've got motion happening at both. So the scapulohumeral rhythm, it hasn't held up to be absolutely true, but the general concept is that we have 120 degrees of motion, around 120 degrees of motion that actually takes place between the head of the humerus and the glenoid fossa. How much range of motion do we have total for the whole complex in flexion?
180.
180. So if 120 of that happens at the glenohumeral joint, how much happens at the scapulothoracic?
60%. I mean,
60 degrees. 60 degrees, right. So we say 120 is twice 160, or it's twice 60. So we say that it's a kind of a 2-to-1 ratio roughly for every 2 degrees of motion at the glenohumeral joint, we have 1 degree of scapula motion, but it's not like you go 2, 1, 2, 1, 2, 1. It kind of changes throughout the range.
Okay.
Does that make sense?
Yes.
So it just helps us remember to look at the scapula. So if this is all the elevation somebody has, we want to see what's their scapula doing, because if the scapula isn't upwardly rotating and protracting, then we don't want to just start really stretching that shoulder and jamming that humerus up into the acromion when it's the scapula that we need to be treating.
So is this why when we were doing the manual muscle test, so you were doing like the middle trap, and then that's what you were looking for, the scapula instead of actually the muscle, because you want to know if the scapula is stable or not.
Right. So yes, I'm looking at, because the muscle moves the scapula, I want to see what the scapula does. Just like when we passively do shoulder flexion, and then we have them actively do it, we're looking at the bone that the muscles move. We're looking at the humerus, right? We're looking at the bone. When we're looking for the mid trap, we want to see, does it control the scapula? Is it strong enough to bring that scapula in? If it can't move the scapula, then we check again. Yeah, the scapula moves, but that muscle can't do it. So that's a weak muscle.
Mm-hmm.
And if they can't do it in prone, they don't get that two inches or so of scapula motion, an inch and a half, 2 inches. What position do we put them in?
Supine.
Side lying. Wait, no.
We want so the motion is the scapula, right? Scapular retraction. How do we put that parallel to the ground?
Sitting.
Yes, sitting. Right? Because now when I'm sitting, now as that scapula moves, it's moving parallel to the ground. Gravity is minimized.
So would you do it across a table?
Arms supported, you can, or even just arms at the side and pinch the shoulder blades. Because when we get to gravity minimized, I taught you how to differentiate upper trap, lower trap, mid trap rhomboids. But you're welcome, Jess, see ya. But when we have to go gravity minimized, it's much more generic. It's scapular retraction. We can't tweak out exactly what muscle it is. We just kind of go generic. Can they retract the scapula? Because everybody needs some work at that point if they can't do it to get gravity minimized.
Mm-hmm.
Can I ask a quick question? I have to go like Jesse, but tomorrow in class, will we get a chance to I know like our time is limited, so we have to get the most bang for our buck, so to speak, with our time. And I know we'll have, the however long in lab, but to kind of tease out some of these, because I think like I can memorize them and write them down, but I haven't really to just put it together. I just don't have a whole lot of confidence in myself when I'm, so I guess what I'm saying is, how much time will we have class time wise to go through some of these lab guides that I know I haven't done other than just doing the CSC?
So I want to go over the quiz. I want as much as we can have done of the CSCs before, like in open lab. I don't think I have any professional behaviors assessments in open lab so that we can get those done. I know people have to be ready because you do have you have a different practical, but you guys have been working on that. And those are only a few pieces. It's a lot less than the manual muscle testing and goniometry. So I think you guys will be more ready for that. But if you've got open lab time, we want to work on that in open lab. So we need to go over the quiz, but I also am going to give you some kind of scenarios, some evaluation papers to look at. And what are you going to do with this patient? So you're going to look at that, figure out what you need to measure and figure out what you need to manual muscle test. And you're going to do that and then come up with exercises for that patient. I probably will also spend a few minutes just calling out a muscle, like where we paired up before and did the rotation, and try and do a little bit of that, because that can go fairly, as long as people are on this, are ready and rotating and not fiddling around, we can get through quite a few muscles that way. I like to do that. And we can answer questions and tweak it out and figure out what's going on. But for those, I like to be able to just kind of go through, and you need to be able to look and say, oh, this is how you test. Oh, I need to test that one. This is what I do. And oh, you couldn't do that motion against gravity. So this is the position I need to put you in, gravity minimized. And we'll have the goniometers out and we'll do some range of motion. So we'll try and do some of that kind of speed round thing. But I also really want you looking at cases, because that's what you're going to need to be able to do. We just did practicals in 110. And if you recall the first practical that you had in that class, it said, PTA, do this. Teach the patient this, and teach the patient this. We're getting you ready to go out to clinicals where it says, these are the goals. This is how the patient presented at the evaluation, and these are the goals. Give the patient exercises. Stretch what needs to be stretched. And it won't say, PTA, do this exercise, do a corner stretch, pec exercise, do isometrics. If you've got a protocol, you'll have that. But if it's just a patient with some pain or, a tendonitis, tendinosis, subacromial pain, it's going to be you looking and figuring out, okay, what do we need to improve the motion of? And what do we need to strengthen? And starting that and figuring out, how do I dose it? Okay, oh, that's too hard for them. How can I make it easier? That's too easy. How can I make it harder? How much resistance should I give this patient when I'm starting them out with a rotator cuff exercise? Not much. But if they can easily pop off 20 repetitions, maybe I increase the weight just a little bit. So it's applying those principles, and that's what we've got to build the time and really get some of that done. But these skills have to be, you have to know how to do the manual muscle testing to get to that point. So as much time as we can. Again, the more of the CSCs that we have done before we come into lab, the easier it is to use the lab time to just really build on that critical thinking and practice those skills and keep working on it. Okay.
So lots to do.
Yes, lots to do. Little bit of time, lots to do.
Thanks.
You're welcome. We'll see if Miss Roseberry will grace us with a little bit of her time, maybe.
Okay. Have a good evening.
Thanks, Kristen.
You too. All right. What other questions? Are we done?
I don't have any questions right now, but I'm sure we have a lot during the test. So
see how many you can come up with before the test, because I can answer those.
okay.
All right. Anybody else? Mary Claire, Austin, any questions?
I'm good. Thank you very much.
You're welcome.
Yeah, thanks so much, Miss Weatherhead, for coming on and doing the extra for us.
Yeah,
You're
thank
welcome.
you.
You're welcome. See you tomorrow.
We'll see you tomorrow. Bye, Bryce. Thank you.
You're welcome. We'll see you. See you tomorrow.
Bye.
Yeah, Austin.